Today we'll discuss the 17 most important questions related to diuretics. So stay tuned until the end and we'll discuss all the questions asked about diuretics. A client receiving IV furosemide means it's a loop diuretic, reports ringing in the ears. Ringing in the ears means tinnitus. Increasing fluid intake. Increasing fluid intake won't reduce the tinnitus in the ears at all, so this is irrelevant, meaning it's incorrect. Assess the hearing change immediately. Yes, when a patient is given furosemide, if you've given it too fast or if the dose is higher than prescribed, it can cause ototoxicity in the patient. This is because furosemide reaches the ear and damages the hair cells within the cochlea in the internal ear. Due to that hair cell damage, there are chances of tinnitus or hearing loss in the patient. So we must assess if the patient is having trouble hearing. If so, the medication must be withheld immediately. So first, we'll assess the hearing change, meaning how the hearing is changing. We'll assess that. So this will be the correct answer. Administering prescribed potassium. Giving potassium won't reduce tinnitus at all. Placing the client in the Trendelenburg position. Giving the Trendelenburg position won't reduce tinnitus either. A nurse is caring for a client taking spironolactone. Spironolactone is a medication that works on the collecting duct, and it's a potassium-sparing diuretic. This means it will increase potassium levels in the blood. Which meal selection should the nurse question? Question? Meaning? So it means the patient is on spironolactone. It's a potassium-sparing diuretic, meaning it will increase potassium levels in the blood, so we must avoid things that contain excessive potassium. Grilled chicken and rice, this doesn't have much potassium. Turkey sandwich with an apple, this doesn't have potassium. Baked potato and banana, both of these, meaning potato and banana, contain potassium. This means they'll increase potassium levels, so this will be our answer. Pasta with vegetables, this isn't rich in potassium either. It's not a potassium-rich diet, so this is also incorrect. You must remember, whenever we are giving a patient a potassium-sparing diuretic or some other medications like ACE inhibitors or ARBs, which are drugs ending in sartan, like losartan, valsartan, and telmisartan, they also increase potassium levels in the blood. Similarly, ACE inhibitors, like medications ending in pril, such as captopril, enalapril, ranapril, all these medications also increase potassium levels. So for any medication that increases blood potassium levels, we must avoid diets high in potassium. So you need to remember the potassium-rich diet because this question is often asked based on diet, like you should remember banana, avocado, orange, potato, tomato, spinach and beans, dry fruit, coconut water, and salt substitutes. All these things are potassium-rich and contain high levels of potassium. A nurse is preparing to administer intravenous mannitol to a client with increased ICP, meaning intracranial pressure is elevated, so an osmotic diuretic called mannitol is given. While inspecting the medication bag, the nurse noticed small crystals inside the solution. Which action should the nurse take? Administer the medication as prescribed because crystallization is expected with mannitol? Crystallization is expected with mannitol, but we shouldn't administer it, otherwise it'll cause a pulmonary embolism once it enters the patient. Shake the bag vigorously and administer the medication immediately. By shaking the bag vigorously, some particles, some crystals might dissolve, but there's no guarantee that all the crystals will dissolve, so this is also incorrect. Discard the medication and obtain a new bag. Since it's expected that in mannitol bag crystals can be found, we aren't going to just discard every bag. So it means we shouldn't discard it. We need to use a different approach. Hold the medication and warm the solution according to the facility's policy to dissolve the crystals and to dissolve the crystals and inspect it before administration. Yes, this is the correct answer because we should withhold the medication for now. Then, following hospital policy, we need to warm that mannitol bag. If we warm it, all the crystals will dissolve, and once they've dissolved, we must inspect it to ensure no crystals remain before we can infuse it into the patient. But remember that whenever we administer mannitol, we must use an inline filter to ensure that any remaining particles don't enter the bloodstream or the body. So this will be the correct answer here. A client taking triamterene develops peaked T waves on the ECG. The nurse should suspect? Triamterene is a potassium-sparing diuretic, meaning it will increase the potassium levels in the blood. So when it increases potassium levels, that's why the T wave becomes peaked. Potassium normally helps with the repolarization of the cardiac muscles, the heart muscles. So when repolarization occurs, the T wave is formed. But potassium is high, it means the T wave will be large or tall. So when the patient has high potassium, that T wave is produced. So hypokalemia? No. Hypokalemia doesn't cause the T wave to increase or become peaked. In hypokalemia, the T wave is either short or absent. So this is incorrect. Hyperkalemia? Yes. Hyperkalemia causes the T wave to become peaked. Hypocalcemia is not related to this, and hypernatremia is also not related to this. A nurse is reviewing new prescriptions for a client receiving IV furosemide for acute pulmonary edema. Furosemide is a loop diuretic, and the patient has pulmonary edema, which means fluid has collected in the alveoli of the lungs. Which prescription should the nurse question first? This means we need to find the prescription that would cause more complications for the patient. Potassium chloride, 20 milliequivalents PO daily. Should we give potassium chloride when the patient is on loop diuretics like furosemide? Yes, we give the patient potassium supplements because whenever we give a patient loop diuretics, they always cause potassium loss. How? Diuretics that work on this loop of Henle are called loop diuretics, and these loop diuretics come here to a structure we call a transporter. This transporter helps shift potassium, calcium, sodium, chloride, and magnesium from this tubular fluid into the blood vessels. That's why we call it the sodium-potassium chloride cotransporter. This means it transports, it doesn't exchange. A transporter means everything moves from one direction to the other. This means when sodium moves from this tubular fluid into the blood, potassium also moves into it from here. It's not like an exchanger where if sodium went this way, potassium would go that way. In an exchanger, as sodium goes out, potassium would come in. But that's not the case here. This is a transporter, which means whenever you give a patient loop diuretics, what will they do? They'll block it. They'll block this transporter. This means sodium can't enter from here, so potassium can't enter, calcium can't enter, chloride can't enter, and magnesium won't enter either. This means all of these will move forward and be excreted. So we can say that whenever a patient is given loop diuretics, they'll have a sodium deficiency or hyponatremia. Potassium will also be excreted from the patient. This means the patient will have hypokalemia, and there are two reasons for this potassium loss. One is that it couldn't be reabsorbed here. Second, if sodium isn't reabsorbed here, it moves forward and reaches the collecting duct. So more sodium reaches the collecting duct than before because the sodium that should have been absorbed here wasn't, since we gave the patient loop diuretics, which blocked the cotransporter. This means this sodium will now reach the collecting duct. Once it reaches the collecting duct, the amount of sodium arriving there is higher. Because it's higher, there are sodium-potassium pumps here in the collecting duct. They reabsorb this sodium. These pumps work like exchangers. If sodium comes in, potassium goes out. If sodium doesn't come in, potassium doesn't go out. You need to remember these two things to understand all diuretics. So, what happens? More sodium reached here, so it had to be taken back in. As sodium came in, potassium was pushed out. This potassium is then excreted through urine. So, two things. First, the potassium that should have been absorbed here wasn't, and sodium wasn't absorbed here either. Now that more sodium reached here, the sodium-potassium pumps in the collecting duct reabsorbed it. This means even more potassium was excreted, resulting in hypokalemia for the patient. Now, we can say that this patient will have a deficiency in their potassium levels. If there's a potassium deficiency, it means we'll have to provide potassium supplementation. So this won't cause any complications, and it's a correct indication. This means we can prescribe potassium supplements to the patient. Gentamicin IV every 8 hours. Gentamicin is an antibiotic in the aminoglycoside category, and all antibiotics in the aminoglycoside category, such as gentamicin, neomycin, streptomycin, amikacin, and streptomycin, neomycin, and tobramycin, all of these antibiotics are ototoxic drugs. This means they go into the ear and damage the hair cells within the cochlea. This means there's a chance the patient could develop tinnitus, and if given to the patient for a long time, it could lead to hearing loss. We also saw that furosemide is an ototoxic drug, and gentamicin is also an ototoxic drug. This means if we give both, the ototoxic effect will increase significantly, and the chances of hearing loss in the patient will rise. So this is something that could cause complications, which is why we need to question it. Therefore, this will be the correct answer here. Let's mark the first one as incorrect. Oxygen at 2 liters per minute via nasal cannula. Yes, we've seen that the patient has pulmonary edema. If there's pulmonary edema, it means the patient will have breathing-related problems, so we can say that giving the patient oxygen is necessary. Thus, this is a correct indication here. This means this answer would be wrong. Daily weight monitoring. Whenever we give a patient diuretics, we need to monitor their intake and output and also monitor their weight daily, so this is also a correct prescription. A client with hypertension is prescribed hydrochlorothiazide. Any drug ending in thiazide means it's a thiazide category diuretic, which assessment finding requires the nurse's immediate attention. This means we need to identify which of these things was unexpected. We need to look at how thiazide diuretics work when we give them to a patient. So the first one is serum calcium, 10.8 milligrams per deciliter. The normal serum calcium level is 8.5 to 10.5 milligrams per deciliter. This means it's elevated. Now, when we give a patient thiazide diuretics, they always work on this part. Here is the first structure. Through this, sodium will go in and chloride will go in. They both go in together. Since they go together, we can call this a cotransporter, and sodium and chloride will pass through here. So this is the sodium chloride cotransporter. Besides this, there's another structure on the side of the blood vessels. Its name is, from here, if sodium goes in, then there's a rule that calcium will come out of it. This means if sodium goes this way, calcium will come this way. So now its name is the sodium-calcium exchanger, okay? You need to remember two things. Here we have the sodium-calcium exchanger, which works in opposite directions. If sodium goes in, calcium comes out. If sodium doesn't go in, calcium won't come out. Whereas here, we have the sodium and chloride transporter. So what happens is that when sodium goes inside, chloride goes in as well. Now, when we've given the patient thiazide diuretics, the thiazide diuretics will come and block this. That is, they'll work right here and stop its action. Now, if its action is stopped, it means the sodium that was here won't be able to go inside. Now, since sodium can't go inside, it means more sodium will reach the collecting duct. More sodium. So some will be excreted and some will be reabsorbed back. Sodium by the sodium-potassium pumps found in the collecting duct. So this means that these sodium-potassium pumps here act as exchangers for each other, right? Sodium in, then potassium out. If sodium doesn't come in, then potassium won't go out. So this means that now when more sodium reaches here, the sodium is taken back in and the potassium is sent back out from here. Now potassium will leave the body. This means it also lowers the potassium level. So the first thing is that thiazide diuretics lower the potassium level. They also lower the sodium level. The second thing we saw here is that there's a sodium-calcium channel. These act as exchangers for each other. This means if sodium goes in, then calcium will come out from here. Now, sodium didn't go in because we gave the patient thiazide diuretics, and the thiazide diuretics blocked this. Since it's blocked, sodium won't go in. If sodium doesn't go in, then calcium won't come out. If calcium doesn't come out, then the calcium in the blood will start being retained. This means the calcium level will increase. So this is also expected in the patient. That is, potassium will be low, sodium will be low, but calcium will increase. So now let's see. Serum calcium, 10 milligrams, 10.8 milligrams per deciliter. This is slightly elevated, which is expected. We've seen its effect. So we need to see which requires immediate attention, meaning when the nurse needs to take action right away. They'll do that when we see some abnormality. So this is expected, so no action is needed here. Serum glucose, 145 milligrams per deciliter. The normal serum glucose level is 70 to 100 milligrams per deciliter. But you have to remember that whenever we give a patient thiazide diuretics, as we saw here, there was a loss of potassium. This means potassium is leaving the body, and there's a deficiency of blood potassium. And you must remember that whenever our pancreas gland has beta cells inside it that produce insulin, but they will only produce insulin when potassium is available in the blood. If potassium is low, then less insulin will be produced. And if less insulin is produced, it means that now the work of insulin will be affected. And the job of insulin is to shift glucose from the blood into the cells. Now, it won't be able to shift glucose into the cells because of the insulin deficiency, so because of that, the glucose level in the blood will increase. It will increase, which means we can say that whenever we give a patient thiazide diuretics, an increase in blood glucose level is a common thing. And this most happens with all diuretics when the potassium level is low. But in this case, it's more, in others, we can't consider it to be increased this much because they aren't given for a long time, whereas thiazide diuretics are given to the patient for a long time. Because of that, we see this increase in the patient. So this is also an expected finding. The nurse doesn't need to do anything about this. Serum potassium, 2.8 milliequivalents per liter. Yes, this was lowering the potassium level in the blood, but this is way too low, isn't it? And the normal level for this is 3.5 to 5 milliequivalents per liter. This means it's extremely low. Now, potassium primarily works to maintain our heart rhythm. It keeps the heart's conduction stable. So this means the patient could now develop cardiac dysrhythmia. To avoid this, the nurse needs to intervene. So this finding is risky. Therefore, this will be the correct answer. Serum uric acid of 8.2 milligrams per deciliter. The normal uric acid level is 3.5 to 7 milligrams per deciliter. This means the uric acid here is elevated. However, we can observe one thing. Whenever a patient is given thiazide diuretics, when those thiazide diuretics leave the body, they work by entering the blood first. After that, if they are excreted from the blood through the urine, then I've drawn the blood vessels here, and this is the PCT part of the kidney. So in this PCT part of the kidney, there are blood capillaries all around it. From here, it exits. There are small channels in the PCT. So the thiazide diuretics will exit from here. They'll come out from here and then leave the body. But along with this channel, one more thing exits, which we call uric acid. If I talk about normal conditions, uric acid exits from here. Uric acid is normally filtered through our glomerulus here, but a certain amount is also filtered from here through tubular secretion. This means it's secreted from the blood capillaries into this PCT. So this is the pathway for uric acid. Uric acid comes through here. However, there's competition between uric acid and thiazide diuretics. When we give a patient thiazide diuretics, the thiazide diuretics also trying to exit from here. So now thiazide diuretics also exit from here to be excreted. Now look, this pathway, this exit route, has been blocked by the thiazide diuretics. This means there's no path left for the uric acid to move from here to there. Consequently, uric acid will start collecting here. Uric acid will increase in the blood. This means we can say the patient has developed hyperuricemia. Therefore, this medication must be given very cautiously to patients with gout, or even avoided. So we can conclude that whenever we give thiazide diuretics to a patient, an increase in uric acid levels is common. This means the nurse doesn't need to take any action for this either. A nurse is assessing a client receiving furosemide. Which findings would indicate the need for further investigation because they are not expected effects of furosemide therapy? Select all that apply. This means furosemide is a loop diuretic that works on the loop of Henle, and with loop diuretics, you must remember that they cause the loss of all electrolytes because they block the sodium-potassium chloride transporter. As a result, all electrolytes are excreted from the body. So, which of these is not an expected finding? That will be our correct answer. Potassium 5.9. Now, the normal potassium level is 3.5 to 5 milliequivalents, but here it's elevated, even though we know loop diuretics lower potassium levels. This means this finding is unexpected, so this is one correct answer. Calcium is 11. Normal calcium level is normal calcium is 8.5 to 10.5 milligrams per deciliter. We've seen that loop diuretics cause the loss of all electrolytes. That means they also lower calcium levels. But here it's elevated, so this is also an unexpected finding, and unexpected findings are our answers. Sodium, 128 milliequivalents per liter. Normally, we saw that it flushes sodium out of the body, meaning it lowers sodium levels, and this sodium level is indeed low because the normal level is 135 to 145 milliequivalents per liter. So this is an expected finding, and we need to identify unexpected ones. Magnesium, 3.2 milligrams. Normal magnesium level is 1.5 to 2.5 milligrams per deciliter. This means this magnesium finding is slightly elevated, so we can say, yeah, whereas it should have been lower. So this is also an unexpected finding. Potassium, 2.9 milliequivalents per liter. Normal potassium level is 3.5 to 5 milliequivalents per liter. Here, the potassium level is low, so this is an expected finding because it causes potassium loss. This is an expected finding, and we had to identify the unexpected ones. A nurse understands the mechanism of loop diuretics when identifying which nephron site is the primary location of action. In other words, on which part of the nephron do loop diuretic act. PCT, proximal convoluted tubule. So this is the PCT, this is the loop of Henle. Now, osmotic diuretics and carbonic anhydrase inhibitors act on this PCT. An example of the latter is acetazolamide. Osmotic. Diuretics like mannitol act here, but they've already worked elsewhere before reaching this point. For instance, if intracranial pressure, or ICP, is elevated, they pull water from there into the blood, which then carries it to the kidneys. Then osmosis occurs again, and they act on the PCT to flush the water out through urine. So this means loop diuretics don't work on the PCT. Next is the descending loop of Henle. They don't work there either. Some students might get confused thinking loop diuretics work on the whole loop of Henle, but that's not true. The loop of Henle has two limbs, the descending limb and the ascending limb. Loop diuretics work right here. This means they work on the ascending limb of the loop of Henle. So the ones working here are called loop diuretics. They will act on the thick ascending loop of Henle. That's the correct answer. Now, for the collecting duct, potassium-sparing diuretics mostly work there, like spironolactone. And this part here, the DCT, is where thiazide diuretics work. So make sure you remember all these locations.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete review crash course. The link is in the description. Now, let's continue with the topic.
A client with a history of recurrent gout is prescribed thiazide diuretics. Gout is a condition where uric acid levels are elevated. We've given this patient thiazide diuretics. Which explanation by the nurse is most accurate? We need the correct statement. The medication lowers the uric acid level. Thiazide diuretics don't lower uric acid levels, they actually increase them. You see, thiazide diuretics work on the DCT, but when this medication needs to be excreted, it's also excreted from these blood capillaries. From there, it's removed from the body through urine. Now, normally, the uric acid is secreted from here and enters this tubule, the PCT. It's normally filtered through the glomerulus too, but some uric acid is also filtered from here into the PCT. So this is the path that uric acid follows. But when we give the patient thiazide diuretics, the medication also takes this path from the blood capillaries into the PCT to be removed from the body. So there's a competition between the two when thiazide diuretics are administered. This means the path is occupied by the thiazide diuretics. Consequently, there's very little room left for uric acid, or none at all. So the uric acid can't leave the blood and won't enter the PCT. This means the uric acid stays inside this capillary, so its level will rise. It rises, meaning it causes hyperuricemia. It doesn't lower the uric acid level, it increases it. So our first option here says that the medication lowers the uric acid level. No, that's a false statement. The medication may increase uric acid levels and worsen gout. Yes, that's the correct statement. The medication dissolves uric acid crystals. No, it doesn't. The medication has no effect on gout? No, it does. It can worsen gout. A nurse is caring for a client receiving mannitol for increased intracranial pressure. Which finding requires immediate intervention? Immediate intervention, this means which condition is harmful for the patient, that's what we need to identify. Increased urine output. Urine output will definitely increase. This is an expected finding, so this means it's incorrect. Dry mucous membranes. Whenever we give diuretics to a patient, fluid depletion occurs, meaning there's a lack of fluid in the body because water is being excreted. So dry mucous membranes are also expected. Bilateral crackles in the lungs. Yes, these are bilateral crackles in the lungs, which means it indicates that something has gone wrong in the patient due to the administration of mannitol. How? First, we need to see how mannitol works. Suppose this is our brain. Inside the brain, these cells have increased in size due to edema, which we call cerebral edema. Because of that, our intracranial pressure has also increased. Now we gave the patient mannitol. This mannitol reached the blood. Reaching the blood means the blood concentration increased. Increased concentration means it became thicker. Now the rule of osmosis will apply. There's more water here, less here. So it will pull water from here. That is, mannitol was given, and now water will come into it. As soon as this water enters the blood vessels, it means these cells that were here will return to their normal condition. That is, the edema will decrease, so the ICP will decrease, meaning it will become normal. The increased ICP will return to normal. Now here, As the water came in, this water that entered the blood vessels means the amount of fluid increased here. Now, this increased blood reaches the heart's right atrium. From the right atrium, it will reach the right ventricle. After that, into the pulmonary trunks, and from the pulmonary trunks, it reaches the pulmonary artery, and from there, it goes to both lungs. Now, since more water was coming from here, more water will go into both lungs. More water going in means that inside the alveoli, water will start collecting inside the lungs or will start filling inside the alveoli. Because of this, we hear crackles or rail sounds in the patient. So this is the problem. That is, it indicates a condition of pulmonary edema. After passing through here, this blood reaches the kidney, and after going into the kidney, mannitol arrives at the tiny capillaries inside the kidney. Now it brings the water here. Now what happens here is that there's more water because mannitol pulled the water from there. Now mannitol comes here into this, the PCT. Now the concentration here has increased, so it pulls the water from here into it like this. So it means it works here through osmosis. But for us, the main problem that occurred here was the crackles. So if crackles have developed in the patient, it means we can say that pulmonary edema must have developed in the patient. So there's a need for immediate intervention here. So this will be the correct answer. Urine specific gravity. Normal specific gravity is 1.005 to 1.030. So this means that this is within the normal range. It's in the normal range, so there's no problem. Specific gravity, when we give diuretics to a patient, means the amount of water in the urine will increase. When the amount of water increases, it means specific gravity will decrease. When the urine is concentrated or there's less water, what will happen to the specific gravity? If the urine is concentrated, the specific gravity will increase. If the urine is diluted or there's more water, the specific gravity will decrease. A client receiving both furosemide and digoxin, which laboratory value is most concerning? That is, when a patient is being given digoxin, if furosemide is also given along with it, which lab value could cause a lot of, problems for us? Sodium 135 milliequivalents per liter. Now normal sodium is 135 to 145, so we can say this is within the normal range, or maybe on the lower end. But you have to remember that whenever a patient is given digoxin and a heart failure condition, so this digoxin reaches the heart. After reaching the heart, it reaches the heart's myocytes. And if you look at those myocytes, in that cell, like this is a heart myocyte, there are some pumps here. Like one is calcium, the calcium channel here. After that is the sodium-calcium channel. And after that, sodium and potassium pump. So what happens from here is that this digoxin will come and bind here. Now there will be competition between both digoxin and potassium here. The more potassium there is here, suppose there's more potassium here, then digoxin will get less space to bind. But if the potassium level in the blood is low, it means there's very little potassium on this potassium pump. If it's low, it means the rest of its location is exposed. Now competition happens. So digoxin will get more space and more digoxin will bind here. If more digoxin binds, it means there are chances of digoxin toxicity. So digoxin toxicity will occur. This means the lower the potassium level, the more space digoxin will get to bind, so the chances of digoxin toxicity will be higher. So these are myocytes, the structure of the cell inside the heart. This one is the sodium and potassium channel. This is the calcium channel. So now, look here, digoxin only comes and binds here on this pump. The name of this pump is the sodium-potassium pump. So that means now remove this calcium from here so you can rule out that option. But on this, it doesn't come and bind on the sodium-potassium pump. So that means you'll eliminate sodium as well and eliminate calcium too. So digoxin binds by coming onto the sodium-potassium pump. The lower the potassium level, the more space digoxin will have. The chances of digoxin toxicity will increase. So we've eliminated sodium here because digoxin doesn't compete with sodium. It doesn't compete with calcium either, so we've eliminated that too. It does compete with potassium, so if potassium levels are low, it means a problem will be created. So potassium is 2.9, but the normal range is 3.5 to 5. This means if the patient has hypokalemia, digoxin toxicity will increase. So this is our right answer. It doesn't have a competition with magnesium either. Which statement by a nursing student indicates correct understanding of why loop diuretics cause hypokalemia? Meaning, why did the patient's potassium decrease if you give them loop diuretics? First option, loop diuretics directly exchange the sodium for the potassium in the loop of Henle. So some students think that since the loop of Henle is mentioned here, and it's a loop diuretic, it must work right here, so they mark it correct. But this is a trap to catch you. Now, what happens here is that this thing is a transporter. Sodium will also go into the blood vessels. And potassium will also go, which means co-transportation happens here, not an exchange. In an exchange, if sodium goes in, potassium comes out. If sodium doesn't go in, then potassium won't come out. So that means we can eliminate the first option because that's exactly what it says. That loop diuretics directly exchange the sodium for the potassium. That sodium is exchanged for potassium. If this comes here, that goes there, whereas no exchange happens here. So this is incorrect. Potassium is lost because sodium delivery to the principal cell is increased. So you have to remember that the principal cells are inside the collecting duct. This collecting duct has principal cells on it. Now, what happens is the option says sodium delivery to the principal cells is increased. Yes, this is the correct answer because as soon as we give the patient loop diuretics, it will block this and reduce its action. It will reduce the action, meaning the sodium that should have gone in from here won't be able to. If it doesn't go, more sodium will move forward and reach the principal cells. So some will be excreted, but there's an attempt to reabsorb some of that sodium. Now, if sodium is reabsorbed, it means they act like an exchanger here, meaning if sodium comes in, potassium goes out. Now, if potassium comes out, it means potassium will be excreted through the urine. So this will be our correct answer. Loop diuretics destroy the potassium channel. No, they don't destroy it. Potassium is filtered less efficiently. Now, it doesn't affect filtration. Because filtration happens here in the glomerulus, this is a problem related to potassium reabsorption. A patient develops a severe allergic reaction after taking trimethoprim and sulfamethoxazole years ago, meaning a year ago when the patient was given antibiotics called trimethoprim and sulfamethoxazole, they developed an allergy. Which newly prescribed medication should prompt the nurse to notify the provider? So, which of these medications can't we give to a patient who's already had an allergic reaction to this type of drug? You have to remember that this medication is an antibiotic and it contains sulfa. This means it contains a group called sulfonamide. If we look at the chemical composition of this medication, so the patient had an allergic reaction because of that sulfonamide group. Now we need to see which of these drugs contains sulfonamide. Now, what exactly is sulfonamide? Normally, when you're looking at a patient, when the patient is given thiazide diuretics, the composition of those thiazide diuretics looks like this. Now, there's something attached here that we call sulfonamide. This sulfonamide is found in thiazide diuretics like chlorothiazide and hydrochlorothiazide. Sulfonamide is present in these diuretics. It's not found in loop diuretics, osmotic diuretics, or potassium-sparing diuretics. We need to find the thiazide diuretics. The one ending in thiazide like chlorth, that's the thiazide diuretic. So look here, thiazide. This means hydrochlorothiazide contains sulfonamide. If we give this to the patient again, there's a chance the patient will develop an allergic reaction. This is the correct answer. The others, like ethacronic acid, are loop diuretics. Spironolactone is a potassium-sparing diuretic, and mannitol is an osmotic diuretic. A nurse is caring for 4 clients receiving potassium-sparing diuretics. Which client should the nurse assess first? A client receiving eplerenone with a potassium level of 5.8 milliequivalents per liter. Now, eplerenone is a potassium-sparing diuretic. That means it's going to raise the potassium level in the blood. And this patient's potassium level is already 5.8. This means the potassium is high because the normal potassium level is 3.5 to 5 milliequivalents per liter. If the patient's potassium is already high and we give a potassium-raising drug like a diuretic, it'll go higher, so we need to assess this patient first. Next, a client on Amiloride, which is also a potassium-sparing diuretic. Their blood pressure is 104/68, which is normal, so we don't need to assess them right away. A client receiving triamterene. Triamterene is also a potassium-sparing diuretic. Their sodium level is 134. That's not a problem. We can give it. A client receiving hydrochlorothiazide. This is a diuretic in the thiazide category. Their calcium level is 10.7. Now, thiazides do increase calcium levels, but we can still give it. It's only slightly high here because the normal calcium level is 8.5 to 10.5 milligrams per deciliter. It's slightly elevated here, but that's not an issue. We can give it. There's no need to immediately assess the patient in this case. A client with heart failure is prescribed Amiloride. Amiloride is, again, a potassium-sparing diuretic. Which assessment finding indicates that the medication is having its intended effect? This means, when can we say that this potassium-sparing diuretic, Amiloride, has started working? If it increases potassium levels, then we can say the medication has started working. Increased potassium excretion in the urine? No. It doesn't increase excretion in the urine because it causes potassium retention in the body. So this is incorrect. Increased sodium excretion with potassium conservation. Yes, it removes sodium and conserves potassium. This is correct. Increased calcium reabsorption in the distal convoluted tubule. That's related to thiazide diuretics. Increased hydrogen ion secretion in the collecting duct. That's also not related to this. A nurse is caring for a client taking eplerenone and lisinopril. Now, eplerenone is a potassium-sparing diuretic, and lisinopril is an ACE inhibitor. ACE inhibitor. So both these medications are given to the patient. Which finding is most concerning? Whenever you see concerning, it means you need to look for complications in this patient to see where a complication might occur. Now, you must remember that whenever we use ACE, you need to see that eplerenone is potassium sparing, meaning it will increase potassium levels. Besides that, you need to look at the side effects of ACE. A for angioedema, C for cough, and E for elevated potassium, because it works on the RAS system. Renin-angiotensin-aldosterone system. It works on this. In this, it will decrease aldosterone levels. Decreasing aldosterone levels means sodium reabsorption will decrease. Sodium won't enter the blood from the filtrate. And if sodium doesn't enter the blood, then potassium won't leave. This means this medication causes potassium retention. So what complication could occur in this patient? Blood pressure of 118/72, that's normal. Then potassium 6.8. The normal potassium level is 3.5 to 5 milliequivalents. This means it's elevated here, and yes, it can increase because both are potassium sparing, both increase potassium levels. This means it's concerning, so this will be the correct answer. Heart rate 78 is within, so that means it's within the normal range. Respiratory rate 18, which means that's also normal. A nurse is assessing a client who has been receiving furosemide therapy for several days. Furosemide is being given, which means it's a loop diuretic, so the patient will have a potassium deficiency. The nurse suspects the client has developed hypokalemia, and which EKG findings are associated with hypokalemia. Select all that apply. Potassium is involved in the heart's repolarization. Whenever the ventricles contract and before the next beat is generated, in between, resetting, that's what repolarization is. This is called repolarization. Normally, you must remember that in our heart, there are these four chambers. The upper ones are the atria, and the lower ones are the ventricles. When the atria contract, a P wave is formed. After that, when the ventricles contract, the QRS complex is formed. Then, until the next beat is generated, the heart needs to rest. So we call that repolarization. For example, suppose there's a runner who's running very fast. After running fast, he won't just stop immediately before running again, right? Now he has to run again. So first he ran fast, and after that, then he'll slow down a bit, then he'll rest for a while, and after that, he'll be ready again. Similarly, now that the ventricles have contracted, the QRS complex is formed. After that, there's the ST segment. So here's the ST segment, and after the ST segment, when repolarization occurs, the T wave is formed. So this is a normal ECG. But when we give the patient diuretics, like loop diuretics, which cause potassium levels to drop, repolarization won't happen. Because repolarization doesn't happen, now what will happen in the ECG that's formed? The P wave will remain normal because the atria contract normally. After that, the QRS complex will also remain normal. But repolarization won't occur because potassium is low. This means that now the ST segment will go down, which we call ST depression. The T wave will either be small, like it might have become smaller compared to before, so that's one possibility, or it might even be absent. After that, an extra wave is formed, which we call a U wave. So this means an extra U wave will be formed. The T wave will either be short or absent, and the ST segment will be depressed. So now let's see what's in the options. Flattened T wave. Yes, the T wave was flattening, so that means this will be correct here. Then prominent U wave. Yes, a U wave is also forming, so this is also correct. ST segment depression. So the ST segment went down, which means this is also correct. T wave. Look, the T wave isn't tall in that, so that means this will be wrong. Widened QRS complex, that's not it either. ST segment elevation, not that either. So those were some of the most important questions related to diuretics. See you tomorrow in a new video. Thanks.